Good morning, and thank you for inviting me. And so I'm very, very much fond about this topic, and I will try also to give you my perspective on how I try to cope with the issue of healthy living in the aging population. And so as background, we all know that HIV patients' average is constantly increasing. I don't have, let us say, a conflict slide, but actually this is my true conflict, that also HIV specialist physicians' average age is constantly increasing. And this is a matter of fact. You can guess who is this boy, this young adult, and actually this person that yesterday got 50 years old. And so actually, this is my conflict, and I reject being considered an aging person. And so that's why I went to the geriatric definition of age. And so you see that geriatrician actually call young as old, any people above the age of 65 up to 75, old from 66 to 84, and oldest old above the age of 85. Given that, what we know about this, let me see, geriatric population. Actually, I put here some of the cohort in which, let us say, papers regarding the aging issue have been published, and you can recognize that actually people above the age of 65 are very poorly represented. And so does it mean that we are speaking about aging, but we do not have aging patients? The issue is that aging patients do exist, and to show you, actually, I give you a French perspective. This is a big cohort from France, in which actually they were able to, let us say, enroll 12,000 people above the age of 50, but what is more interesting is 430 in the, what they call, geriatric area. And of course, what you can see here is that the first and most important issue is that the geriatric patients, compared to what they call the elderly patient, have got higher prevalence of comorbidities, because we know that comorbidities are age-related issue. Nevertheless, let us go a bit inside what is this population. And actually, you see that in the subset of the 400 people that were above the age of 75, the age at art initiation was 64 years. Ooh, who are they? Actually, they are not people aging with HIV in this particular cohort. These are people who got HIV at an older age. And so, first of all, the first thing I needed to stress, the fact that if you get into the aging scenario, it's very important you distinguish who are the people who are aging with HIV and so got HIV infection for 10, 20, more than 20 years, or people that actually got infection yesterday, and maybe the burden of comorbidities was already present because they are elderly people. Okay, and so in order to cover that, actually what we did was to try to build up a new cohort, a cohort which is a true geriatric cohort. We called it a geriatric patient with HIV. We called it the GEPO cohort. At present is an Italian cohort, but we hope to develop at, let me say, an international level. And actually the objective of this cohort is to describe multimorbidity, polypharmacy, and of course antiretroviral use in this special population. And so far, I will present you some data that will be presented next week in the comorbidity meetings and later this year in the Glasgow meeting. And what we wanted really is to look, of course, at the age of the people, but really compare the age of the people with the duration of HIV infection. That is, people who got HIV infection for less than 10 years, from 10, 20 years, and more than 20 years. And of course, we say that people who are now more than 65 years and are infected for more than 20 years are our champions, are the champions of their generation, are the one who really survived from the first HIV epidemic, were exposed to pre-heart, and now are still living with HIV. Let me give you a glance and compare it with the Italian population, a comparable Italian population. And so you see, if we look at the population between 65 and 75, we were able to recruit 950 people and compare to HIV negative. And you can see that some difference do exist. And so our patients are actually thinner than the general population, have higher prevalence of dyslipidemia, and gets more drugs above antiretroviral use. And so is it true what we say as a whole, that our aging population have got more comorbidities than the general population? Apparently this is not true, but actually if you stratify population according to HIV duration, now it comes a very significant difference. And so once again we can say that the year you live with HIV makes the difference with regard to the issue of the burden of comorbidities, and this is even more relevant if you go in the people who are above the age of 75, that in this population is represented by more than 300 people, and once again you see a very huge difference regarding all the different comorbidities. And so let me summarize this to say, well, the issue of multimorbidity in HIV people compared to HIV negative is higher, but the difference between HIV population and HIV negative is more apparent and is independently, let me say, associated with the duration of HIV. This is the first issue. The second issue is, well, our population is aging. And so what will be the future? I think this very important paper from Athena Court is very interesting because actually it tells us that by the year 2030, if you see the yellow column here, actually it will be very much apparent that actually not just the population will get older, but most of these older people will have multimorbidity. And so the issue is that we will not here to discuss single comorbidities as we did yesterday, the bone issue, neurocognitive issue, but rather the heart issue, but rather the fact that these comorbidities are contemporarily present in the same individual, and multimorbidity will be the norm in the HIV setting. But does this multimorbidity really explain the clinical burden of a geriatric patients? And so let's go to the geriatric field, and actually what geriatricians tell us is that you can compare two people with the same age, you can have the same comorbidities and the same pattern of multimorbidities that these two patients have, but actually this patient may still be different. And so it's not just because of comorbidities, it's not just because of multimorbidity, there is something clinically relevant that makes the impact of multimorbidity be different in the management of the patient and in the total patient health. How we call this in the geriatric field is frailty. And so actually, how to define frailty? Well, I attend geriatric meetings in some years, and there's still big debate regarding definition, but not rather definition, but rather how to operationalize frailty in the clinical setting. Can I use it in my clinic every day to distinguish patients who are at risk or who have already multimorbidity, yes or not? So the first way to distinguish it is a phenotypic approach. Which car is frail? Well, you don't need to be a doctor, you don't need to make an engineering to know that these two cars that were built the same year are totally different. You see the painting, you see the crystals, you see the wheels, they are different. And so either you say, well, what you see is what you get, or rather you can even count all the different items. The paint is different, the wheel is different. You count and you can summarize it into a scale. This scale is called Frailty Index that count all the number of, let me say, of deficit that an individual may develop. And so this is an approach that we currently use in our clinic, and what you can see is that in our everyday life, we collect many variables, and what I did was rather to ask an engineering to count the number of variables anytime I visit a patient and return me a score which goes from 0 to 1, that is a 0, not one single deficit present, 100. All the variables I collected are pathological, and actually you are already dead, and this is well shown in general population. But you see, what is interesting is that the distribution of frailty in my cohort is perfectly normal, okay? And actually, inside my frailty index, there's not age, but you see that the correlation with age, both in men and women, it's impressive, okay? And so I can guess the age, but I can guess more the health associated with age. And so this tells me that frailty index is a measure of a biological age that I can assess. Why I introduced this? Because I want to give you number. And so according to what is known in general literature, we divided our population in fit people, in frail people, and in most frail people, that are people with frailty index above 0.4. Why? Because if the Athena court showed us what is the projection of multimorbidity by the year 2030, actually what we were able to do was a modeling study in which we were projecting not just the age of the people in our cohort, and it's quite impressive to see that by the year 2030, 95% of my people attending my clinic will be above the age of 50, okay? But what is more impressive is that the proportion of most frail individuals that nowadays are 24% of my population will turn to be double, that is 48%. And so this tells me that something is changing, not just because the people are older, but because people are getting frailer. And so we need to manage this. 2030 is very close. We need to organize our health system differently if we believe that most of our people will have multimorbidity and 50% of our people will be frail. Okay, and so you see the process I would like to make you go through is that also if you consider our meeting, our literature, we've been discussing so much about drug toxicity, and after a while we realized it was not just because of the drug, it's because of also the patient, the environment, the genetics, the epigenetics that makes organ disease turn to be comorbidities. Comorbidities are now not enough. We need to describe multimorbidity. Multimorbidity have different impact according to the frailty of an individual. And why is this important? Because actually what we want to prevent is in fact a disability. Many times when I visit a patient, I say, well, what I wish for you is exactly what I wish for me. That is, not living 120 years, but rather dying the night before I turn to be severely disabled. This is what we want to prevent as doctors. And so you see, if disability is the ultimate goal in which we clinicians need to do something, actually, we need to think that disability is a process in which we need to assess impairment, limitation, frailty, and assess disability, which is, of course, not easy to do. Just to give you a glance of a recent paper that was produced by Christine Erlandson, what she was able to show is that, in fact, a disability that is assessed with instrumental activity of daily living, that is, are you able to cope with your medication, laundry, shopping, telephoning, transportation? Well, this is an old definition of disability, but still what is used in research. Actually, well, it may be strange, but actually is 2 times more prevalent in HIV patients compared to HIV negative. And what is interesting is that frailty is a strong predictor of disability. This is why it's so important to measure frailty so that to understand who will turn to be disabled in the future. What are the prevalence of these disabled conditions, what we call geriatric syndrome? Well, hearing impairment, these are San Francisco population, people above the age of 50, strange age definition again. hearing loss, 14%, mobility impairment, 21%, urinary incontinence. Did you ever ask about your patient about if they have urinary incontinence? 1 out of 4 in San Francisco has. Okay, visual impairment, false. And so actually, once again, we need to understand, is there a prevalence of geriatric syndrome? Are they difficult to collect? Well, if I wanted to address the issue of fall is one of the most important geriatric syndrome, actually, I just need to ask you one question. Did you ever fall in the past 6 months? And actually, this is the result in my cohort, that is 12% now fall, but actually, what happened is that projecting this existing data to 2030, actually 29% of my patients will turn to have geriatric syndromes, and actually 34% in the year 2030 will be disabled. And so once again, these are the projections that are informative for us regarding the issue how we need to change our health system if we think that our patient will not just be older, will be disabled. And that's why we need to prevent disability now, because if you assess frailty, frailty is a reversible condition, disability is no more reversible. And so I want this 34% of my patients not to be disabled by the year 2030, and I need to do something now. Okay. Once again, we've been thinking a lot, well, how happy we are, HIV patients are living longer, and life expectancy is as good as the general population, or even better. But actually, which kind of life expectancy are we looking for? I think that we need to rewrite the papers about life expectancy, because what really matters to us is healthy life expectancy. That is what the proportion of people who are living without multimorbidity, without frailty, without disability. And so this is something we totally don't know. And so this is why I think we need to collect more data regarding healthy life expectancy, and we need to act now. And so in the second part of my talk, I will try to give you my perspective how to address this issue. And so, of course, the big issue is how to manage HIV as a chronic condition. The first issue, obviously, is to get HIV diagnosis, and yesterday we discussed how to manage the HIV negative results, but how to make people go to do HIV testing. Of course, start and treat. This is something that is under research now, and of course, address co-morbidities, promote lifestyle changes, and this is the topic of this meeting. Try to reduce the burden and the risk of polypharmacy, and yesterday there was a contribution from Turkey about this issue, and also how to manage this comorbidity in the context of a HIV infection. But my issue here is that many times when you go to meeting, they say, well, this is the cascade of care, and what we are speaking about now is healthy living beyond undetectability. That is here. Okay. The perspective we need to change is that taking care of the total patient health is not something that is of value beyond undetectability. Is something that definitely will change the cascade of care. This is an important message. And so having a total care health issue will be something that will promote access to HIV testing, retention in care, and obtain undetectability. And of course, we'll go above undetectability. But don't split the issue. And so total patient care is something that is primarily focused for improving this horrible cascade of care that is still the picture of our issue. What our primary issue is to provide antiretroviral therapy. Let me go to the JEPO court and show you what are the drugs that are prescribed for people above the age of 65 in Italy. And so what you can see here is that the standard triple regimen is not prescribed to all. And actually, more than 30% of people above the age of 65 are taking either mono or dual therapy. So that's an issue. This tells us that the standard regimen doesn't fit the elderly people, the geriatric people above the age of 65. And actually, this gradient of the use of mono and dual therapy is well depicted according to the duration of HIV infection, which actually tells me that the risk of mono-dual therapy is really function of the presence of multimorbidity. What does it mean? Is that presumably, if I have one single comorbidities, I don't need to change my antiretroviral therapy. But actually, if I have heart disease, bone disease, and kidney disease, of course, the standard regimen doesn't fit. Especially the fixed dose combination doesn't fit. And so really, this is why clinicians need to do something, even if many times there's not really properly designed trials to do so, but actually this is our clinical practice. We move to unconventional regimen, and the issue is that they must work. Okay, and actually this is interesting that multimorbidity is also a driver for an RTI sparing regimen, while we didn't really find a big issue regarding boosted versus unboosted regimen according to multimorbidity. I'm quite curious, is that because, let me say, Italian clinicians are not so prone to switching, or it is because the current let me say, boosted protease inhibitors are considered safe, or because these elderly people are complex enough from a virological point of view that cannot avoid boosted PI in the regimen. All of these may be true. So the issue is that what is the ideal regimen, how to address the regimen that I would like to use in the elderly individual. Are there some safer drug or some more easy to use drugs compared to others? And let me say, at least for the issue of multimorbidities and polypharmacy, I think that INSTI are very easy to use at least. Unboosted PI also, of course, boosting may produce some complication. NRTI, it depends which NRTI you have, and hopefully, actually, the advent of TAF will make the difference with regard of the feasibility to use an NRTI combination for elderly individual with lots of kidney and bone disease at the same time. But apart from antiretroviral therapy, this is a picture of a patient of mine that just came in my clinic. We provided the drugs not just for antiretroviral, but also for the comorbidities. Okay, and so our pharmacy, Italy is a strange place. Everything is free with regard of drugs, and you go to your pharmacy with your luggage to take the drugs. Okay, and actually the issue is that good for you? Actually, in general literature, we know that actually polypharmacy is associated with adverse event, with drug-drug interaction, with increased cost, with increased pill burden, with adherence issues, with falls, and with mortality also. And so let me show you actually the proportion of prescription in the past 10 years in my clinic. And so I don't know if you are aware how much we change the way in which we prescribe drugs. Of course, vitamin D, but also ACE inhibitors, beta blockers, statin. And so actually, all together, let me say, it's interesting to show you, this is outside antiretroviral therapy, that, let me say, 10 years ago, when I had a 40 years old people, actually, the mean number of drug compounds above antiretroviral therapy was actually 1. Now it's 2. And this is interesting. If I have 4 comorbidities, 10 years ago, I was giving you 4 drugs above antiretroviral therapy. Now, if you have comorbidities, I'm giving you 6 drugs. And so actually, it's not just an issue that we recognize more comorbidities, but we treat more heavily. And of course, it may be useful, but it may also be harmful. And so actually, that is why it's important to address this issue. And so it's interesting to see that this is HIV negative population, this is HIV positive population. You see that once again, according to what is the duration of your HIV infection, the proportion of polypharmacy is significantly increased. And actually, this is not true for any drugs. I was somehow surprised the fact that actually we prescribe more statin than geriatrician. Wow. Okay, and so this gives you the flavor that when you get into geriatric medicine, what geriatricians do is to take out drugs, because of the level of evidence of the benefit of drugs in an elderly people are much less than in the general population. And so actually, so far, my understanding is that we treat comorbidities exactly in the same way if you are 45 or if you are 75. But actually, this is not true in a geriatric perspective. And so this is why we need to understand actually what are the pattern of comorbidity treatment. Once again, let us go further on. Let's think how to improve the care of HIV as a chronic condition. This JAMA paper never mentioned exactly HIV as an issue, but definitely let me say HIV is a chronic condition, and this is a model that tells me that if I want to improve primary care in HIV as a chronic condition, I need to work with the health system, but also work with the comorbidity. And so I'm very glad that after my talk, there will be a community perspective about how to treat HIV in this. And so what is the issue with regard of health system, how to deliver system, and the decision support, the clinical information system. Let me give you an example. And so how to deliver the system. This is my clinic. You see, in my clinic, a patient gets in, we try to keep the patient at the center, and actually in the same place, lots of people and lots of non-physician gets around the people. And so we've got a nurse, we've got a non-HIV specialist, we've got pharmacists, we've got occupational therapists, we've got psychologists. And actually, most of the data, it's impressive, are not really collected by us, but are rather collected by patients themselves. Because if I've got information, I need to have information about quality of life, frailty, disability, geriatric syndrome, physical function, mental health. It's just the patient that can tell me. I don't have a blood test to do it. And so actually what we do is really have quite an extensive way in which ask the patient about all these issues. And a very simple thing is that you are in front of my clinic in the waiting room. There's somebody that gives you an iPad and says, please fill in this quality of life. Please tell me if you had a fall. And now there's a so easy way with Google that while the patient is in the waiting room, actually he fills in, and while he enters, I have already the results, not just the question. And so I can comment it in front of the patients. Okay, and so this is something cost zero. You need to have an iPad. That's all what you need to have. And actually, this is very informative because the description of frailty and geriatric syndrome and disability are part of the clinical judgment of what we call the comprehensive geriatric assessment of a patient. The second issue regarding decision support is the risk of drug-drug interaction. And so we all have in our iPhone the Liverpool chart. Who says that they are not good for the patient? And so it's not for us, it's for the patients. We need to educate the patient regarding the fact that there's lots of drugs that are taken out of the counter, and they need to get informed if there's any risk, not just with antiretroviral therapy, but also among the many comorbidities that the patient has. A third issue is regarding the possibility to improve information about well-being and about lifestyle of the patients. So this is a Gilead study we have just started. It's called My Smart Age with HIV. And actually what we do is to provide to all our patients a Fitbit device like this, and we know day by day how many steps they had, how many hours they slept, but it's not just for us. We don't get them for us. We won't get to the patient. And we join this information with question, with beeps that comes out 2 times a week to say, hey, how are you now? What are you doing now? What's your mood now? Did you have any social interaction? All these issues is called ecological momentary assessment. That is, I want to have instant information about the well-being, and I can put all these issues in, let me say, a health index that the patient can look and say, well, I'm fit, or this month was not that great for me. Okay. Second part to deliver health system is the involvement of community. Once again, this is a website that I think is very important, mobilize community to meet the need of the patients. I think that a place in which HIV patient may have a blog, may put their experience, may exchange their experience regarding healthy living is very important, and I know that the following of all these issues is quite relevant. But also self-management and self-treatment is important. This is a beautiful book that was published by an NGO called Justry. It actually tells the patient how to do a self-management wellness checklist. And so ask the patient about their condition at a daily basis, at a weekly basis, and from time to time, because actually this is something that is really turned to be important from the health perspective. Last but not least, think that HIV is still a stigmatizing condition. There's a stigmatizing condition which is intrinsic in the HIV status, but also sometimes is related to homophobia. But actually remember that ageism is a new stigmatizing condition that affects quality of life. And so we need to think that having an older individual with HIV, we will add more stigma to this patient, and we need to find, from a community perspective, but also from a health system perspective, some answer with regard of how to cope with a new stigma. And so these are my take-home messages. I think that comorbidities are the prevalent clinical picture of contemporary HIV disease. The association of comorbidity into complex multimorbidity picture describe the complexity, the clinical complexity of the patient. But of course, when multimorbidity is the norm, frailty and disability turn to be relevant clinical outcomes, much more than CD4 and viral load. And total patient care allowed to integrate the need for reaching undetectability with the need to take care of comorbidities. It's not just beyond undetectability, it's in the process towards and beyond undetectability. HIV care implies a switch from an interdisciplinary approach, that is what is considered now to be more advanced, into a multidimensional approach in which most of the items are patient-derived, are patient-related outcomes that are part of the evaluation of the patient. Doing so, we will be able to have a better patient visit diversification. So far, HIV patients always had the same screening test, CD4 viral load and transaminase and hemoglobin, and that's all, regardless they are young, old, comorbidity, no comorbidity, frail, no frail, disabled, non-disabled. Definitely, HIV now means nothing with regard of your health status. You need to provide care according to your health status, which is driven by this issue. And the increasing number of older patients with frailty, geriatric syndrome, and disability depict a geriatric HIV scenario. We have a cardio-geriatrician, ortho-geriatrician. Now we have geriatric AIDS. Okay, it's a new branch. It's something in which geriatrician needs to be involved, and health system and community need to be involved so that to ensure high quality care. So just to end, I think that we had a target provided by UNAIDS that is 90% diagnosed, 90% on treatment, 90% virally suppressed. Let me add 90% fit and 90 years. Thank you.